welcome you to put any information in the chat that you'd like to share with the group. I've already kind of started that process, and we're going to talk more about this in just a minute. Well, hello everyone, welcome. This is Jacqueline Summers with HealthTie. It's nice to see all of you. We're here today to present with JC Adams from Cloud9. I am going to just take a minute while we gather to tell you two different pieces of information. The first one is I'd just like to encourage everyone to mute their microphones. I know JC is going to allow you at certain points in his presentation to ask some questions, but until then, we just wanted to make sure everybody can hear and has all the video capability that they need. The first thing I want to share with you is that a future presenter, Alice Bouchard, has emailed today saying that she has a workshop coming up on July 16th. And I'm going to take a minute and let Kim tell us more about that.
Yeah, I'll just take a minute. I did hear Alice present a few months ago. So she's the parent of a young adult who had a ski accident when she was a young child and experienced a traumatic brain injury that resulted in a fairly significant cognitive disability as well as a physical disability. And her daughter is a success story who lives in her own house and really manages her life with the help of several apps and low-cost apps that Alice herself found and was able to integrate into her daughter's life. It's just a great story, and I think anyone who is interested in app technology or supporting people with disabilities in an effective, low-cost way, Alice is a great presenter. So I just wanted to give that shout out.
Thank you, Kim. And again, Alice will be presenting for HealthTie is actually on August 13th. So if you want to learn more about what Alice is doing. The second piece of information is that Zoom is changing their process. And so we have been using the same Zoom link and information for a long time now, and that will likely change. So I just want each of you to know that there will probably be a password or a new process for getting into these meetings. I'll share that information in the next newsletter. So with that, I'm actually going to step back and really welcome JC Adams. He has been fantastic to work with. We've met a few times now, and I'm just inspired by what he's developed, he and his team. He's got some of his team on the call today, and thank you, JC, for telling us more about Cloud9.
Thank you, Jacqueline. Again, I'm JC Adams, founder and CEO of Cloud9, a telehealth innovation company based in Austin, Texas. And we're certainly honored to be sharing the work we're doing with HealthTie members. The role you all play as a test bed for innovation is very important for communities like yours. And also we as entrepreneurs, we thrive on getting initial feedback from community leaders with your type of perspective and who are also looking out for the best interests of your people. So first, I must thank Jacqueline Summers. Thank you for that kind introduction. We've been inspired by you as well and finding out what a caring advocate you are for your community. And we've been very fortunate to spend time with you and other colleagues learning about the good work that you all are already doing for Alaskans healthcare, as well as some immediate challenges and opportunities that you're all seeking to address. So I will share some slides and some visuals. If you give me just a moment. Can everyone see my screen? Great. Okay, so starting with a little background, Cloud9 began about 5 years ago. I'm a serial entrepreneur, and I've launched several companies in a variety of industries, always with tech being a main component. But several years ago, I had lost a really close friend to rapid onset of bipolar disorder. And this ended up being the fourth friend I lost to mental illness, along with 3 family members. And it seems like I've spent a lot of my life trying to help individuals get access to care when it's very difficult without enough providers, without proper reimbursement, insurance coverage, this issue of stigma. And I grew up in a very rural area where there simply were not services, not as rural and with some of the frontier areas issues that you face with Alaska, but I'm certainly sensitive to those issues. And I've been very fortunate to find a team of individuals with decades of experience in healthcare technology, public health, and public safety, because as you can see on the slide here, our mission has been to address the healthcare needs of underserved populations. And in speaking with public health providers, we had looked at narrowing our focus to a certain degree on individuals and populations known as high utilizers that are very costly to serve. And often those individuals are dealing with physical and mental illnesses combined with substance use, who often get caught in this failed cycle of non-treatment and readmission, landing inappropriately at medical emergency rooms if they have a mental illness or behavioral health condition. Some of these individuals get caught in the criminal justice system and come out in worse condition, often landing on the streets and adding to the homeless population that we see across the country. And our partners and customers in this have been community health centers, mental health centers, FQHCs, and other types of entities, as well as cities, counties, and states. So our telehealth approach in general is integrated care collaboration. So our software allows for full data sharing and communication and clinical workflows for multidisciplinary care teams, but fundamentally, we started off with behavioral healthcare workflows, and that's the population that we address. So individuals that have those needs, but also who need to be treated with wraparound services from care teams like what you see on the screen here. And this is just an example configuration. So in addition to psychiatrists, counselors, therapists, we want them to be able to coordinate to treat the patient and do so with connecting to other clinicians like primary care, as well as substance use recovery coaches. Home health care teams can be a key component, as well as social services like food, clothing, childcare, housing, as we address the social determinants of health needs of these individuals. And then also, when there's a crisis, first responders often get involved, and we'll show you how that can be an important collaboration as well in just a moment. So in addition to having all these care teams be able to collaborate with communication and data, this can be a standalone solution connecting patients to those care teams, but it becomes exponentially more powerful when we can connect through our secure API to electronic medical records or other types of systems. I mentioned first responders, so EMS, law enforcement systems, as well as being able to connect to things like pharmacies, third-party analytics tools, and even other healthcare applications that may be useful for the patients that we're serving. Oh, and one thing else I would like to point out is data security is very important. We've built our services on Microsoft Azure for not only healthcare compliance, but also government agency compliance. And we also look at the patient as being in the one that should be in control of their data. So we always get patient consents to share that data with the end customer, which would be that healthcare providing entity or the community. So once we deploy this application, this is an example of the front end workflows we call prevention. And this is a proprietary closed loop workflow we call talk, test, and track. So with talk, we have the ability for HIPAA compliant voice, video, text, scheduling, seamless, but unlike video conferencing solutions like Zoom, what we're using here today, it's designed in mind with patients and their care teams with these collaborative workflows. Also, we want to have the ability to provide testing for these individuals. So That would include various assessments, health assessments, mental health assessments for depression, anxiety, substance use disorders. We can even include patient satisfaction surveys and other types of information that you need to collect from patients from time to time with that same capability that we have with the testing component. But also in between those talk therapy sessions and when we're tracking our outcomes through testing, we want the ability to track ongoing, let's say, if we're talking about behavioral health care, we want to be able to track ongoing emotional and mental states for these individuals, and being able to also connect to healthcare devices, let's say FDA approved medical devices, or even consumer wearables, so that we can collect behavioral biomarkers, which can give us more insights into how a patient is doing. And also with our prevention solution, it's not just for that ongoing communication from an outpatient point of view. Here's an example of how this can be important if someone actually has a highly acute condition and they end up landing in a hospital or even a county jail. What happens often is these individuals are released without much other than their possessions, and they're not really connected back to the public health system, and too many are not connected back to services. So they get caught in this failed cycle. What we prefer to do is make sure that those individuals get an app like ours installed on their personal device, so that before they leave, they can be shown how to use it. They can connect and set up an appointment for the next outpatient appointment with, let's say, a psychiatrist, a counselor, a therapist, or a social worker, or even send their first text message to a case manager. And this sends them out the door with that lifeline connection, so that we're engaged and we don't lose track of those individuals and they fall through the cracks. And that can be a tremendous advantage to removing barriers and reducing these ER and jail visits that are too frequent, and improving outcomes for a population. We've shown results. Here's an example of a case study we did with Austin patients, and we did this with some partners we were working with at Verizon. And this was with low-income patients who had serious mental illness, and because of the nature of our deployment, we did a survey in advance and asked these individuals if they could take part in this. And many of them said that they were concerned if they had a new enough smartphone. For instance, they may have had a flip phone, or that they perhaps could have not had enough data on their plan. So what we did is we overcame that barrier by providing a smartphone and a data plan. And for this population, we showed that 68% of those improved engagement. We had a 95% net promoter score averaged out from both patients and providers. And 100% of those completed appointments had a positive patient outcome, while also reducing no-show rates. What we're starting to see now in the wake of COVID-19 is that as many of these public health entities are forced to shift to telehealth, they're seeing their no-show rates reduced to almost zero. So this is this shows the power of having that access and convenience for patients. So, one thing else I want to point out with this is that given that Alaska is unique, I know that we all know that you not only have all of that beautiful wide open space up there, but you also that also can bring about a lack of broadband coverage that you have in the area. So we've seen this a lot here in Texas. We have frontier areas, for instance, in western parts of the state, nothing like what you have in Alaska. But for folks that are out in villages that are often hundreds of miles away from your cities there, we we believe that some of the work that we've done with Verizon in the past can help overcome some issues in serving rural areas. It's of great interest to our team to try to continue to overcome some of these issues and see how that we can optimize a telehealth program working within those constraints. So having that cross-platform mobility can help in that the patient's phone can be taken anywhere that we can get onto a wireless hotspot. But there's also commercial and residential antennas and boosters that can be used to address those needs. And then something else that we would like to explore at a later time is also seeing what we can do with some of the FCC telehealth programs that can help deliver some funding to add some solutions and infrastructure that may be helpful. So I think maybe this might be a good time before I move on to the intervention solution. If anybody has any questions about the prevention model that I've described for ongoing treatment of patients. Anybody have any questions?
Hi there, this is Vernee Berner with the Alaska Native Health Board. I just want to let you know that I made it onto the call.
Thank you for joining. Any questions before we move on to the intervention model? Okay, so in addition to what we explained for ongoing treatment, here's a configuration for individuals that perhaps may be in crisis. So when it's really a bad day, we need to be able to have a different set of care teams that can come in and solve problems. So many of you may be familiar with co-responder models, and this is where you have communities across the United States that are trying to intercept individuals and get them care, provide these ER and jail diversion programs by sending lower level clinicians out to ride along in ambulances or law enforcement cruisers. And those co-responder programs can be very effective when they can actually arrive at the scene, but logistically that's very challenging. In urban environments, when it's rush hour traffic time, it's just not going to happen in a timely manner. In rural areas, the distances are too great and we can't be everywhere at once. So imagine taking a co-responder that's been trained for providing services out in the community, or even individuals who've worked with MCOT or ACT programs, these mobile crisis outreach programs. Imagine having them instead repurposed to be a call center clinician at 911 dispatch, acting as an air traffic controller with eyes and ears on the scene, and being able to help triage an individual remotely from the call center and coordinate with others like an actual MCOT or ACT team that's out in the community, or with paramedics, and being able to connect back to behavioral health care providers in the area. Being able to connect with friends, family, social services, as well as law enforcement. And what we can do here is efficiently treat at the scene and coordinate care. And here's an example of the workflows that we've designed here. We have data that can be available for care team members remotely. If you're a healthcare provider that is able to see personal health information, then you can see the information on a patient that perhaps is already in the system, in the electronic health record for the community. And as a first responder is arriving at the scene, that information can be made available to the care team as soon as we're notified that this is an individual that has been in treatment before, and we can identify them through the phone number they're calling from, the address we're responding to, and other sets of data, and get that information disseminated amongst the care team in advance. And then once they're there, we can quickly triage and determine the risk level. We can have a talk therapy session right there on the scene, connecting that first responder acts as a facilitator, connecting a remote clinician to the individual in need, and then they can provide that that individual in crisis with a large smartphone or a tablet, and then the first responder can step back and simply hold space for them to have their therapy session right there on the scene. And then we can start to organize treatment protocols to get them served. And in essence, what we're doing here is, again, breaking that failed cycle of dropping people in ERs and jails, and getting the number one priority is to see if we can resolve the crisis at the scene. And then, if needed, we can route to additional treatment options. If an individual is off of their meds, we can get them to the pharmacy or have a prescription delivered to them, get them to social services, friends and family. Again, those MCOT teams, diversion centers, or if a hospital is needed, let's get them to the right hospital and make sure that it's appropriate for their needs. So we've been effective. Here's some results for deployment that we had in Houston with the Harris County Sheriff's Office. This data was analyzed by UT Health Science Center. And with our model, we showed that 97% of Cloud9 consults were superior or equal to having that ride-along clinician. And the initial efficiency of turning something like this on generated a return on investment for the community that exceeded 600%. And there's a shortage of clinicians across the US, and this really functions as a workforce multiplier. So instead of one clinician being in one first responder vehicle, you can imagine what happens when we have one clinician that's available in 30 or more first responder vehicles at any given time. And then I think the more important metric is on the right here, where we showed an initial 22% decrease in these mental crises landing in ERs and jails. If this were fully scaled up, available for first responders in a community the size of Houston, this could save hundreds of millions of dollars, given the waste that is prevalent when mental crises land in these inappropriate settings. So that's very attractive to community leaders as we're trying to provide more compassionate care for these individuals, and we need a way to pay for it. And these savings actually act as that way to fund this. So this fits within what's known as the sequential intercept model, if any of you are familiar with this. Also, the Crisis Now model. I think that this was put together pulling some of the 4 core services on the left of these Crisis Now components. On the right, you'll see that we connect to multiple care teams with voice, video, and data across all regions for all the citizens. Regarding peers, they're included as part of a key care team member within our platform. Also, at some point, I'd like to speak with someone up there about some new opportunities that we have with time banking for peer support. Also 24/7 access, care teams can respond, of course, 24/7, the app's always available, but when they're not available, we wanna make sure that these autoresponders and chat bots can help patients feel connected at any given time. And then also having shared data and communication between care team members to drive coordination is very important. So today we've shown our prevention model for ongoing treatment of mental illness, as well as the intervention model. We eventually want the intervention model to be put out of business by a prevention model. We really want to route people over to this closed loop system so they can stay in treatment and out of crisis. So to summarize, I think the best way to outline these benefits for the patient would be that we're mainly increasing access to care. And we certainly want to help these individuals avoid any interactions with ERs and jails. And as for clinicians, we can certainly help them increase billable time, reducing no-shows, as we discussed. And then for the health system, this improves outcomes. It greatly increases efficiency. For public safety, this allows for faster crisis resolution and avoiding transports. And for the community as a whole, we want to decrease those costs and according to the World Health Organization, for every dollar you invest in community mental health care, that can result in a $4 to $5 increase in productivity for your economy. So we want to look at, just as I think I saw with HealthTide, we want to see that healthcare shouldn't be seen as a drain. It should be seen as a value add for the community. So I'll stop there and see if we have any questions or comments. And also I'm joined by a team member, so maybe they can jump in as well, and you can meet them, and they can better answer any questions.
Thank you, JC. That was absolutely wonderful. It's a really complex subject, so I think you lay out your option, the possibilities very well. Some of the comments that are coming in are specifically about Verizon and broadband in Alaska, and I want to quickly address those. Both I have and Kim has been in conversation with Verizon. We actually do think that this is something that would be possible, especially in Matsu and in Anchorage. And so there was also some interest in what possibly the CARES Act could provide in rural Alaska. And again, I've reached out to the Denali Commission. I believe Kim is also in conversations with them. And I believe there are ways to move forward and increase the capability of broadband and telehealth in rural Alaska and make systems like Cloud9 available. And I know that having had conversations with JC and John Colburn with Cloud9, that there's possible workarounds that we could do. So I know that other people are interested in those technical capabilities, but I'm wondering if others want to address other questions to JC and his team.
Just feel free to unmute and ask your question, and JC and I will do our best to answer. This is John Colburn.
John, this is Charlie. I'm curious, how deployed is your system in terms of users or communities, or however you measure that?
Yes, so we've launched initially in Texas. We started off being deployed with independent clinicians, psychiatrists, counselors, and therapists that have private practices so that we could learn the workflows that we were showing earlier. This is how we advanced development of this closed loop system here, talk, test, and track, just really focusing on that connection between clinicians and their patients. And we did that with 350 private practices starting here in our home state. But trying to fit with our mission, we knew that we needed to serve the enterprise. We started looking at hospitals and health systems like Baylor Scott and White, Ascension, Seton, and systems like that. We're currently speaking with Texas Medical Center down in Houston. But really, we found our best fit, Charlie, with the public health community mental health centers. So organizations like Integral Care that serves Austin and Travis County. We're working with, and then we've spoken with other large cities as well, like Houston, Dallas. We serve even smaller communities, mid-sized cities and community health centers as well. And now we're starting to get more interest outside of the state. So yeah, we're looking at Nevada, Massachusetts, California, as well as some others.
Good. Thank you.
I believe there's another question from either Carolyn or Benjamin Brown. So is there a question?
Sorry, that's my son who's Benjamin. I'm Carolyn Brown. I just have a quick question. What's been your experience in dealing with language barriers in a crisis mode 24/7, and how have you managed to deal with that, or is it a problem? We have lots of problems in Alaska with that.
That is a very good question. And what we've done thus far is looked toward our healthcare providing organizations having multilingual care teams available. Now, the first translation of our application is going to be in Spanish here in the U.S., but we also have identified some partner solutions that are working on issues of language barriers across a large list of translations that can be integrated with this, or it can be a warm handoff. So if we quickly identify that we are trying to address the needs of a patient that where we do not have someone on the care team that that can address that can speak that language, then what we can do is work with this partner solution. And I'm happy to share a list of some of those solutions that are actually starting to enter the marketplace out there that are quickly deployable for telehealth.
Thank you.
Wonderful. Carolyn, that's an excellent question. So thank you very much for asking it. I believe Cindy Middlestead also had a question. Cindy?
Sure, thank you, Jacqueline. So I'm curious, oftentimes when individuals are in crisis, it's generally not the time to consider introducing this. So I'm also curious, from a family member who we've got experience with, oftentimes in the public health system, we find that the frontline care team or care coordinators are, I dislike this word, but I'm going to use it, are burdened with a caseload that is beyond their management. And oftentimes it's difficult to rally care coordinator and outreach team to do that outreach work. Have you been able to identify any metrics or ease of implementation and demonstrate that this changes that engagement between a clinician and those in crisis?
Yes.
Again,
John on our team has done this work. John?
Yes, hi. So folks, I'm a psychologist by my training, worked in community mental health for about 10 years, and then have migrated around the United States doing different kinds of work with behavioral health systems. And at a late age got involved with this process, this technology. But the situation you described, particularly in encounters between people in crisis and police, often are very charged and hard to manage. I don't hesitate to tell you the statistic, but it is very grim, and that is that persons with serious mental illness are 16 times more likely to die in encounters with police than non-mentally ill. African-American men, in comparison, though a terrible and horrific situation, are 3 times more likely to die at the hands of police compared to white males. There's an underlying part of our culture that has a very hard time knowing how to, number one, understand, be kind and compassionate. And in my experience, people who chose to go into the field of behavioral health and medicine, for that matter, are more inclined to compassion in many ways, and are given more permission to express that and to use their training to make it happen. That doesn't preclude the fact that in some crises with psychiatric people or people who are on drugs, they're not able at that very moment to calm themselves enough to accept the help we want to offer them. And that's one of the reasons why we're not saying we should get rid of police and that they're not useful, in that they can help us create a safe space in which the person either needs temporarily to be taken to a crisis setting where they can be protected, or given once they realize the police are not going to throw them in the car and lock them up, they may calm down. That was our experience in our pilot in Houston. And but the point you raise is of concern, and it's part of what we do when we do our training on how to use telehealth in this setting, how to broaden the role of the clinician who's communicating with the first responder to say, well, this may complicate your life a little bit. Part of what you're doing is coaching the officer before you get involved directly with the patient. So they know to not be, if the situation doesn't need some great restraint of the person, then to step back and let safety take over. Sorry for the lengthy answer, but it's a very great question, and it is complicated, and we're not claiming that our solution works 100% of the time. I like to think about each individual we've been involved with that kept them out of a jail or out of an ER, or kept a police officer from losing their cool and shooting someone who actually was trying to commit suicide by cop, as the weird phrase that we use. You know, to be able to, as part of our training with the police that's offered all across the country, crisis intervention training, part of what they're taught is to really identify people who can be de-escalated to the point where they're not trying to get themselves shot or otherwise restrained.
John, I thank you very much for that response. What I'm going to invite everybody to do is just take a minute and put your contact information in the chat if you want to hear more from JC Adams or John Colburn. We are going to continue to try to engage them and possibly do some pilot projects here in Alaska. I'm very excited about our relationship with them. I do think that it's a real opportunity for us to work to do better with behavioral health here. Thank you all for coming today. This has been an absolutely wonderful presentation. Thank you very much, JC. Thank you, John. And I look forward to talking to you again soon. I'm happy to make any introductions or do any follow-up connections that anybody would like. So thank you all. And I am going to end the call there and say, I hope you have a wonderful day. So thank you all. Take care.
Thank you all for your time today. Take care.
Okay, thank you. Goodbye now, everybody. See you in a couple of weeks.
Thank you.